Father in heaven, we give you glory, honor. We bless your name. We acknowledge that this is the day you have made for the annual conference for the communicable and non-communicable diseases.
We are going direct into business in this pre-conference, and we have a number of organizations that will be leading us in the pre-conference.
You've already been welcomed to today's conference, and we are privileged as the Uganda Pediatrics Association to set the stage and kick off the conference.
We encourage our patients who have asthma to have daily inhaled corticosteroids as the mainstay of treatment, other than using salbutamol whenever they need, because continuous use of salbutamol is associated with hyper-responsiveness, or your chest responds worse, what people call addictive to the drug.
In order for us to address, everyone needs to know what sickle cell disease is, how it is transmitted, who is at risk of getting it, not when they have grown and they're going for premarital counseling. It's too late.
Many children are actually not looked after by their own parents. They're looked after by guardians. And I know there's still a little bit of stigma in almost all diseases. How are we handling that?
Richard, we appreciate that actually the half-life of dihydromethamphepaquine phosphate, DP you mentioned, is about 42 days. But I note you are giving it weekly in sickle cell disease. What would be the sequela of prolonged use of DP, given that actually it's given weekly compared to its half-life of 42 days?
Do you think children with asthma it's okay to engage in all these kind of activities?
Ministry of Health, we really need to up our game and ensure that we have these screening kits for sickle cell at the NMS and they reach to all government facilities. Thank you.
Out of this conference, what are we saying we can do next year, beginning January, to make sure that our communities are saved from some of these probably easy to solve problems? Thank you.
I used to think that asthma and sickle cell diseases are not treatable. I'm just getting to learn from the presentations here that we can treat these diseases.
Epidemiology of childhood conditions has evolved over time, just as we had one of our oncologists talking about how the cancer epidemiology has evolved. So people who trained a long time ago may not be very aware of the distribution of childhood illnesses of date, but also more information is out there. Research is being done and there's more new knowledge. So the in-service training alone is not enough. The pre-service training. We need to do more in-service training as well to continue to improve the knowledge, continuous professional development of our doctors, both in the tertiary setting, but also in the primary care level, to give them this new knowledge so that as children come, they are better equipped to diagnose them, to suspect, diagnose them, refer them or manage them with the new knowledge and the new capacity, the new skills, the new instruments that are out there now.
We have very many people with sickle cell disease in the country, about 20 to 30,000 babies born every year with the disease. And Uganda has number 5 with the biggest number of sickle cell disease worldwide. So we need to work together, Ministry of Health and other partners, to address sickle cell disease and other non-communicable diseases. And I suggest that capacity building is built not only for health professionals, but for everyone, so that we can sensitize the community and also provide good services for the patients.
Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Thank you. You're most welcome to our national annual communicable and non-communicable and the 19th Joint Scientific Conference. Today is the first day of the main conference, but it is the third day of the entire conference week that started with a couple of pre-conference sessions. Before we start our day, we are supposed to be officially starting at 9, and we have quite a packed agenda for today, so we must keep and observe time. And this will go out to all of you who are going to be sharing, even in the breakout sessions. We must keep time if we are to achieve the objective of this meeting. So to bless our morning and our day, I would like to call upon our sister, Diana Cherotin. Please, you can step forward and give us a word of prayer. In the meantime, Mukama will be getting ready to come and briefly share with us what transpired over the last 2 days. So Diana, you can come and give us a word of prayer.
Good morning. Let's stand up for a short word of prayer. Heavenly Father, we want to thank you for today. We want to thank you for the gift of life. We want to thank you for the gift of health. Thank you for keeping us from Monday and for the sessions that we've had from Monday. For Almighty Father, we pray that today, as we get into the main conference, that the sessions we're going to discuss, that you may enrich them and you may fill us with ideas, and you may also give us the ability to absorb what we're going to discuss. Father, give us strength, give us the wisdom, and give us the knowledge during today's sessions. In Jesus' name, I do pray.
Thank you, Dana. You can give a hand clap. Once again, you're most welcome. We have a few messages to pass on. We have a big number, so we request that you keep an eye on your property as much as possible. And there are many activities taking place around this venue, so ensure that you keep an eye on your property, your bags, but most importantly, know your neighbor. Your neighbor should be able to introduce him or herself to you by name and where he or she is coming from. If you want, you can confirm with us if you're not sure, and that is the only way when we can account for whoever is in this room. So my name is Michael Msime from the Ministry of Health, and I'll be guiding you through this morning. For those of you who are joining us today, for us to keep on the discussion, the rapporteurs have prepared a short presentation to guide us on what has transpired over the last 2 days. And to do that, I will call upon Semei Mukama to step forward. You have 5 minutes to quickly update the members on what we have been able to capture and what we can consider as we continue our discussions this week.
Thank you very much, MC. Good morning, ladies and gentlemen. For the past 2 days, we've been here, and a lot has been happening. We've shared a lot of things, and therefore, to highlight what has happened for those 2 days. Yes, the 2 days have been days of discussions where we've had many technical people coming in and sharing with us a number of things, and therefore we dubbed it integration in action, innovation, community voice, and transition leadership as an acronym for what has just transpired in this pre-conference for the last 2 days. The objectives of the pre-conference really, as a nutshell, is we've been able to showcase innovations, driving diagnostics, integration, and sustainability of communicable and non-communicable disease services in Uganda, but also being able to review lessons from centers of excellence and regional referral hospitals as they transition post-donor funding, and then to explore opportunities for knowledge, sovereignty, local capacity building, and multi-sectoral collaboration in non-communicable disease integration. The key themes that have been covered in the past 2 days include diagnostic innovation, where we've focused on GeneXpert with its technical technology and hybrid upgrades, the integration of HIV, TB, and NCD services in regional referral hospitals and elsewhere, reimagining sustainability and transition for Center of Excellences, strengthening biomedical engineering, supply chain and digital data systems, community engagement and communication for service uptake, knowledge sovereignty, and Ugandan-led research for policy. Those were the key themes that we've covered. Of course, there are others, but we just picked out those that really stood out. Some of the highlights from the presentation we've had there. We had one where the introduction of the technicolor GeneXpert, enabling third-one tests beyond TB that we know using those same machines. There is also one that was made by regional referral hospital directors that shared integration experiences, combining pharmacies, shared staff, integrated outreach schedules, hub and spoke referral models, and joint budgeting for HIV, TB, diabetes, and SCDs. Then we had a highlight from the CS Center of Excellences, where they reflected on the 20 years of United States support, calling for a structured transition that retains national capacity, integrating COs into Ministry of Health infrastructure. And then lastly is from Flavia, where she urged the community recognition and investment, and she said integration should not lead to disintegration. She emphasized the continuity of HIV community structures during transition. What are some of the cross-cutting issues that we've had in the previous 2 days? Workforce shortages and limited biomedical engineering support, infrastructure and power backup gaps affecting equipment uptime, fragmented digital systems and weak data interoperability, stockouts and supply chain delays, community awareness and demand generation deficits, and then unclear transition plans for Center of Excellence and funding continuity. Those were the cross-cutting issues. And then what are some of the innovations or research that has been shared? Quite a lot. A lot of innovation has been shared. But in a nutshell, we've had a learning from Jinja Regional Referral Hospital's chronic care clinical model for multi-disease integration, the hydroxyl and then malaria chemo prevention trials for sickle cell disease. We've had a lot of learning around sickle cell. And then treat Interact project for teacher-led mental health promotion. We've had sessions where we've learned about mental health among the children and the young people. Locally fabricated spaces for pediatric asthma management. People were here and they were able to be blessed by how they can locally innovate around supporting children that are suffering from asthma, and then community-based HIV support models, sustaining integration, post-donor transition. Again, integration, but also transiting from the donor support is an area that we are focusing, that has been focused on for the previous 2 days. Policy or practice recommendation is that we've been able to learn from the pre-conference 2 days. Adopt the hybrid GeneXpert upgrade model to maximize existing infrastructure. Then strengthening regional integration committees that will be linking districts and regional referral hospitals, including Center of Excellence as formally in the Ministry of Health Transition Technical Working Groups. institutionalizing biomedical engineering and maintenance funds within our hospital budgets, and also establish Uganda Aid as a domestic funding mechanism for health security. Those were the policies or practices that came up as recommendations. Of course, there were others, but we picked a few. I know the final report will have a lot. We had some quotes that we picked out from day one and part of day two, and these are here. You can read them for yourselves. Integration should not lead to disintegration. We should be very careful. As we're focusing on integrating, then we shouldn't result into disintegrating. That was stated by Flavia. Second is that integration is everyone's role. If we are to promote service delivery, we noted that this is it should be on each one's agenda. And then in green, we can transform a crisis into an opportunity. I think you can understand what I mean. This Dr. Andrew Kambugu pointed it out. We can transform our crisis into an opportunity. And then the last quote was, mental health improvement starts with me, it starts with you. Areas of improvement for that we've noticed: time management to allow deeper discussion on transition financing. So if we come here, let's try to save time. Limited time presentation from district and lower level health workers. Need for better synthesis of technical and community language for non-specialists. Areas follow-up: develop a policy brief on pediatric non-communicable diseases integration. Convening a multi-sectoral roundtable with those stakeholders and more, and then preparing a policy brief on integrated service delivery for Center of Excellence's transition. Thank you very much. I would like to send acknowledgement to the rapporteur team. Thank you very much.
Thank you, Semei. A big applause to our rapporteurs. They are capturing quite a number of these issues. And from this, they'll be following up with the action points to make sure that we transform them into action plans and see how to take these issues on after the workshop. Ladies and gentlemen, we are going into our first session for today. And I'm glad to report that we have our chairperson already with us and all the three presenters. And I would like to call upon Professor Moses Kamya to step forward and introduce the topic and the panelists who are going to take us through today's session. You can give him a hand clap. You will have up to 10:30 to see how to manage the team.
Yeah, thank you very much. May I request the panelists to come right now? Dr. Stavia, Dr. Yo, Professor Gua today. Could you please come? So as they come to redeem time, I wish to welcome you to this first session. This is the first day of the main conference. As you know, we've had a pre-conference for the past 2 days, but this is the first day of the main conference. So welcome, everyone. I'm sure there are still many people outside there, but I hope they will walk in sooner than later. Now, this first session is titled Communicable and Non-Communicable Diseases. What is the status and what are the strategic priorities? Where are we and what strategies do we want to put in place? Now, my name, for those of you who may not know me, I'm Professor Moses Kamya. I'm a professor of medicine at Makerere University. And you will allow me not to spend a lot of time on protocol. Can I say all protocol observed? Yeah, each one of you is very important, so that is why I don't want to mention all of you, but let me just say protocol observed. And to mention is to omit, and to omit is to offend. So I don't want to offend anyone. So we have this session of 1.5 hours. It's going to be an interesting one. And I must say, I'm truly, truly excited because this is an unprecedented conference, one that brings together colleagues from the academia, from Ministry of Health, from development partners, from districts. So it's kind of, we've not done this before. And thanks to people who thought about it. I know Commissioner Stavia here is one of those who thought about, give her a clap. It's wonderful to have all of us in one room so that we don't say, oh, look here, Makerere produces a lot of evidence, but it is never used. It is not implemented. So right now we have an opportunity to say, okay, we have this evidence, how do we together move it forward and implement it? And I think that will be an opportunity to accelerate disease control and prevention in Uganda. So I'm going to introduce our first speaker, Dr. Stavia Turiahabwe. All of you know her. She's a commissioner, Communicable Disease Control and Prevention at the Uganda Ministry of Health. She holds a bachelor's degree in medicine and surgery from MUST, Mbarara University of Science and Technology, and a master's degree in public health from the Land University in Sweden. She has over 20 years experience working with both government and non-governmental organizations addressing global issues and HIV, TB, leprosy, and surveillance for multiple diseases. I know her more as a TB person, although she has done everything. So Dr. Stavia, you are welcome to give your talk. Just as a preamble, she's going to talk about communicable diseases. I work a lot with malaria. With malaria, we've made a lot of gains. We used to be very high up there, 40% prevalence of parasitemia. Then we came down to 9. Then we've climbed up again. So, we have a situation where we've controlled the disease, and then we get these upsurges. So to maintain it there is really a challenge. How do you maintain the gains? And Dr. Stavia is going to tell us what the strategic priorities for making sure that we control communicable diseases in the country. So you are welcome. You have 15 minutes. Of course, you're a commissioner. I won't stop you, but I hope. Okay. If you agree that I will stop you, then I will. Oh, you have 20 minutes? Of course, you're a commissioner. You can take 20 minutes. If you take 17, I'll be happy. Over to you, Stavia.
Thank you so much, our chair, for this session. I am very delighted this morning that the full conference has started. I want to thank the teams that helped us with the pre-conference, all your sessions that you organized were very interesting and thrilling to the participants. Thank you so much. I want to thank, as they prepared the slides, the teams that worked with me to organize this conference. We had a number of committees, but the most important committee that has made this happen is the one on science that was led by Professor Kamya. I want to thank you for the work that you did with the teams from the ministry and from Makerere and other universities. I also want to extend my sincere thanks to the sponsors of this conference. You all know what is happening in the global health financing landscape. It has not been easy. And in that, I want to thank every individual who paid their coin that they should be here. We need to learn that also in Uganda, you can organize paid up conferences. When other people organize, we want to go. Maybe we have interests there where the conferences are organized. But we need to attract other people also to come to Uganda. So I want to urge the academia that we need to move this even to another level, to attract as many other stakeholders beyond the borders to participate in this conference that we have started today. I want to thank the organizations. Different people brought different pieces on the table, and they were able to make our conference a reality. I'm talking so that more people are entering. I know I have a few minutes, but we want to share these strategies with all of us that are attending the conference. So the people who are outside, kindly mobilize them to enter so that we are speaking to all of us that are coming for this conference. The communicable diseases, I think, have been the business of the Minister of Health for a long time. But we are still having these diseases. And the reason is they are able, if you facilitate them, we have facilitators, to move from one person to the other, unlike the non-communicable ones. So together we need to think how best we can deter that movement of the pathogens from one person to the other. And there are simple things they tell us most of them are preventable. And no wonder the department is a prevention and control. So can we work together to prevent these conditions? Over the days, the 2 days, the teams raised the issue of awareness. I think the first day, and people are like, now we need education, we need labor agenda, and truly we need them. We don't need to run health as if it is only in the health sector. We need other stakeholders on board to support the prevention of diseases. As individuals, we need to be party, but also as organizations. Talk about the churches that we have, the religious institutions that we have, and mosques, then the schools, and many other organized groups where we can market this prevention agenda. It is very key that we prevent these diseases. When the prevention is done, then we'll be able to have a leap. He has just said malaria, we reduce and then it comes. Why does it come back? We need to ask ourselves, who is the most affected? Why are they affected? So there are quite a number, but my talk will basically focus on the ones that are causing us more trouble as a country. And these include HIV/AIDS. HIV/AIDS is causing us trouble as a country. A very good number of Ugandans are living with HIV. They need our care. But there are also quite a number who are still getting infected. The other key disease that we'll be talking about is definitely malaria. Malaria is causing the most need for someone to visit a health facility in our country. On top of that, it is also causing death. Most deaths are due to malaria. So the malaria elimination agenda, which we'll be talking about, let me know when when to touch the remote IT. The malaria agenda is calling all of us to be on board, to use the interventions that work, which we have been having. Then the other disease that we are going to talk about is tuberculosis. Yesterday, the session on non-communicable diseases, when they talked about the lungs, they touched it. Now, it is still a communicable disease, but it also causes non-communicable disease or status. We know that the bacilli is curable. But once it has taken time in your body without being diagnosed, it damages the lungs. And that damage, that if you happen to have a cavity, it will trouble you for most of your life, even having had the disease itself cured. But also it causes other things in the lungs that will compromise your life after the cure is achieved. The other disease that we have with tuberculosis is leprosy. Leprosy, we eliminated it as a public health issue, but we want to achieve zero status. And what this means is that no Ugandan should contract leprosy. We can still have refugees come with it, but we see how best to have a status where no Ugandan is contracting the disease. Now we have hepatitis. Hepatitis is also here with us. So we will focus on those diseases, but we also have immunizable diseases. And the profile of this has been nation of malaria. So we saying case management across communities. Yes, on preventing malaria, we will still continue to use our mosquito nets. They are effective, they work, especially when you are sleeping. But when you are not in your bed, the mosquito net will not stop the mosquito from biting you. So we need other interventions. We are implementing indoor residual spraying, IRS. We want to increase the number of districts where this is being done because we have seen it has a very high impact on reducing the burden of malaria. Larval source management, where it is applicable, and also vector control across the sectors, including the private sector. On malaria surveillance, M&E and research, we need to continue to, and we are calling upon the academia. The reason we have combined with you is for you to pick the issues that require more research and support us to improve them, but also strengthening the surveillance generally and recording for malaria. Under governance, we need leadership is key at all levels. If we don't have people who are concerned about malaria, then we will not eliminate malaria as we have targeted. So we still have high burden districts. You can see them majorly in the northern part of the country. These we want to reduce them by 2030, like I have said. No district should be in the red category. And these are some of the tailored interventions for high burden and low burden, but I will not go into this detail, but they include the interventions that I just described. The key thing here, we are going to strengthen effective coverage and also add tailored and contextual specific issues to eliminate malaria. What works in District X may not work in the other district. Tuberculosis remains a high issue in our country. We are among the high burdened countries globally, with about 96 people falling ill annually, and also 37 of our TB patients having HIV. We still have new cases of leprosy, especially among children. So to accelerate the end of TB and achieving zero leprosy, we need to integrate TB in all our services across levels, engage communities, maintain TB and leprosy services in the primary health care, work in a multi-sectoral manner. I have told you the issues that, the factors that facilitate these diseases to move may not be within the health sector, address the challenge of drug resistance, and improve on diagnosis access. And these are the targets that the team has set. We moved from the 90-90-90 in the last planning period. Now we want to target 95-95-95 for TB prevention, TB treatment coverage, TB treatment success, and reduce the burden of leprosy. These are some of the things that we have seen working, including innovations where we are using the X-ray. For a long time, we used the symptom screen. It leaves quite a big number of the people with the disease, but the X-ray is able to see if there is any problem in the lungs even before you start developing symptoms. And we have X-ray together with artificial intelligence. We have the gene expert, it works, but accessibility is key. We have now the new things coming up, the point of care things that are also coming up, and the shorter treatment regimens are also with us. So for HIV, we know about our prevalence at 5.5, but different for different groups, with most burden being with women at 6.9. We also have the number of people living with HIV estimated to be at 1.53 million. The new infections, although have reduced, they are still high. You can see on the graph, the blue line is for new infections, the red line is for HIV-related death. Until we have the blue line fall below the red line, we will not achieve epidemic control. So we still have a lot of work. You can see how the gap between the lines. So the ART coverage has increased, but we still have people who don't know their status that we have to target. We also have to address the key drivers of the epidemic so that we can achieve epidemic control. This is how the prevalence is distributed across the country for HIV. The highest burden being in central and southwest regions, Rakai, Masaka, Kalangala, and in Kampala. The lowest in the north and northeastern part. The high incidence districts, we have Fort Portal City, Chotera, Bunyoro, Kampala, and Soroti City for young people. That is where the biggest burden of HIV in young people is. So we need to focus on epidemic control and reach this by 2030. We need to sustain the gains where we've reached the 95-95. Where we have not, we need to make sure we reach those targets. We are focusing on integration. We are focusing on community engagement. So addressing the persistent disparities, responding to changing funding landscape, integration, and the need for innovations, including digital health, driving the priorities that we have set. So when we thought of the outcomes, the first outcome is in reducing new infections, and we want to achieve a 70% reduction. We want to reduce the mother-to-child transmission of HIV, syphilis, hepatitis. We want to optimize HIV care. We want to strengthen the system for HIV services. So on outcome one, reducing the new infections, we want to strengthen HIV testing and linkage services. We still have people who get tested, but they don't get linked. We want to integrate medical male circumcision in our primary services. This was being driven by the donors, but now the donors have said, this one is no longer priority. So we need to think about how to support our system to offer medical male circumcision to the men. Then condom programming is staying, adolescent and young girls, pre-exposure prophylaxis, and then pre-exposure and PrEP is repeated. We have now a new Brit on board, the Lena Capavir. People are thinking it's a vaccine for preventing HIV. So we need to think, how do we maximize the use of this? I'll not go into details here. On EMTCT, we want to expand prevention access for pregnant women. And for us to achieve this, this is where integration becomes key. Now, the pregnant women, there is a primary responsibility for maternal child rated services. But we want to prevent HIV in that group. So we need that group on board to own that service for us to have better results. Universal access for ART among the women who are HIV positive, follow-up of babies and their mothers to make sure that they continue on care. We have seen babies who get infected after leaving the labor suit during breastfeeding times. On care and treatment, we want to ensure that we deliver high-quality, integrated, and person-centered HIV care. And we expect to achieve the 95 for people being on ART and those on ART being virus suppressed, and then establishing chronic care where this is feasible, and HIV is one of the services in these chronic care spaces. Mother to child comes back again. On governance and coordination, there are a number of things that we need to do to strengthen the system to be able to deliver and achieve the 95 targets. So the key focus here is on high impact interventions, including integration of HIV in primary and essential healthcare services, focusing on places where there is high burden, like I have told you, and also offering person-centered services and multi-sectoral approach to HIV. The HIV is also helping us, time up, I'm almost done, with the control of syphilis and hepatitis. And for hepatitis, the good news and what is going to help us reach the end is the birth dose for hepatitis for babies who are being born. So we need to see how best every child who is born is getting hepatitis vaccine within the labor suite or postnatal ward before they leave. But also those who get delivered outside the facility, I know there are still some, we need to target them. EMTCT capacity, we have talked about it. I will not dwell a lot on it. Opportunities for integration have been highlighted. We know TB HIV has been happening, but we need to get into the space of maternal child health and be able to get the mothers at risk receiving the services. We need to get in the space of the UNEP to integrate mental health and other services to be able to have HIV accessible, services accessible. In TB, it is a similar thing. So it means we need to work together to be able to address communicable diseases. Don't say for me, I am doing maternal child health services. I have nothing to do with HIV. I am doing NCDs. I have nothing to do with TB. We need to work together. The same people that we are serving for different conditions are the same people that will develop either of the two conditions, either communicable or non-communicable diseases. So is the communicable disease team. We need to be concerned about non-communicable diseases. We also have neglected tropical diseases. They are still important, and where they are, we need to strengthen the surveillance for them and also offer the treatments that are available. I want to thank everybody who has helped me to put this together, but also who is doing whatever you are doing across there to make sure that we end these communicable diseases. We are now calling upon you that we have new vibe, new energy to eliminate malaria, control the HIV epidemic, and also end tuberculosis and achieve zero leprosy. Thank you.
Thank you very much, Commissioner Stavia. I think that was excellent. Really telling us the priorities or the strategies that we are going to implement as a country. I think they are really comprehensive. If we can do them, I'm sure we shall achieve the outcomes that she has mentioned. Now, we are not going to ask questions now, but you can keep your question until all the panelists have talked. So please write down your question. For example, she talked about, having zero malaria deaths. And we know very well that the cause of severe malaria and death is, most of it is attributable to delayed care seeking. When people delay to seek care, that is the most important cause of severe and complicated malaria and death. So how do we make our people seek treatment early? I mean, how will that happen? So anyway, you prepare your questions, tough questions for Stavia. So we are going to move on to communicable diseases by the two gentlemen seated here. I will introduce them. Dr. David Guatude and Dr. Oyo Charles. Now, let me give you a little bit of flavor about non-communicable disease. Sorry, communicable disease. Where we work in rural Uganda, and you may want to write down this statistic, the obesity was 2.7 in 2013, and it rose to 7.2 in 2025. 2.7 in 2013 to 7.2 in 2025. Now, in one of the genders, allow me not to say the gender. Yeah, it could be your own guess. In one of the genders, it rose from 4.2% to 11.5%. Now, these are rural women. Oh, I've ended up. These are rural women. And we are wondering, what are these? The rural women, used to work a lot and what? So what's happening to people? Of course, they are not urban people. These are rural women, rural folks. So you can see that, we have communicable diseases. They are a problem, but also non-communicable diseases are also a big problem. So right now, allow me to introduce the Next speaker, Dr. David Gua today, who is a professor of epidemiology and biostatistics at the School of Public Health, Makerere University. He has been working there for over 32 years. And over the past 10 years, his research interest has been in the area of non-communicable diseases, focusing on characterizing the epidemiology and evaluation of the effectiveness of appropriate interventions for prevention and control of NCDs. He's been part of the team leading the NCD risk factor and surveys in Uganda. So Professor Gua, today you are welcome. Unfortunately, you don't have a lot of time, but do your best.
Thank you very much, Professor Kanya. And may I have the slides, please? Okay, thank you. So I'm going to present to you information about the prevalence of non-communicable, of the risk factors of non-communicable diseases in Uganda. And the question is, where do we stand as a country? And we know that from risk factors, if we don't control these, then we have diseases in the future. It is the risk factors that are driving the diseases. Now, a little introduction. NCDs are the biggest contributor to global mortality, and we know that 70% of global deaths, or equivalent to 43 million deaths, happen annually. And although in sub-Saharan Africa, communicable diseases are still the major contributors to mortality, the proportion of contributed by non-communicable diseases is increasing. Actually, it is estimated that probably by 2030, we will have 50% contribution between communicable and non-communicable diseases, unless we do something. And an important way to control NCDs is to focus on reducing the prevalence of the common risk factors to contribute towards meeting SDG 3.4, which is to reduce NCD mortality by 30% by 2030. I'm not sure if we shall meet that target in Uganda, because all indications are that mortality due to NCDs is actually increasing. So we need to work very hard. And so what we do is to identify and monitor trends in the prevalence of the risk factors, and then design appropriate interventions to reduce the prevalence of these. And the School of Public Health has been collaborating with the Ministry of Health, specifically the Department of Non-Communicable Disease, to document the prevalence of key risk factors of NCDs and also monitor changes in the prevalence of these.
What is happening on the ground.
There are about 8 NCD risk factors that should be a major focus for prevention, and these can be categorized into 2 groups: the behavior risk factors, including alcohol use, tobacco use, inappropriate consumption of fruits and inadequate consumption of fruits and vegetables, inadequate physical activity, and then sedentary behavior. And then we have the physiological and metabolic risk factors, including raised blood pressure, raised blood sugar, and overweight and obesity. And you have already heard from Professor Kamia that obesity is increasing in our communities. This is a little bit of a technical slide of how we selected the sample size. Probably we skip most of the details on this slide, and you can view it later when the slides are shared with you. But briefly, it shows how we selected a sample from the whole country so that the findings that we obtain represents the picture in the country.
But the passion, the work,
Okay,
the
the results,
remains.
the prevalence of behavior risk factors, as you can see, I don't have a pointer here, I don't know if there is any, but you can see from the first set of the bar, the prevalence of current tobacco use reduced from 9.6 in 2014 to 8.3 in 2023. So we have made some good progress in terms of tobacco use. We are reducing. I hope we can keep that trend. And so we have also reduced the current use of all forms of tobacco. So the first one was smoked tobacco, and then the second one is all forms of tobacco. We also reduced from 11.2 in 2014 to 10.1 in 2023. And then on alcohol use, we have actually increased from 28.5 to 31.1%. So if you are seated either side of others, you look on the left or on the third, the three people seated next to you, one of them is a current alcohol user on average. And then inadequate consumption of fruits and vegetables. To me, this is the most disappointing because in this country, we are still lucky that we have a lot of fruits and vegetables, but we don't consume enough of these. And in 2014, 87.8% of adults in this country were not consuming the recommended 5 servings of fruits and vegetables. Although this improved and reduced to 86.4, the prevalence, as you can see, is still very high. Most of our people are not consuming enough fruits and vegetables. And then sedentariness, this reduced from 26.6% in 2014 to 31.9% in 2023. So you can see we are sitting more, and actually when you get this data, most of the problem is in urban areas. And looking at it deeper again, most of it is among employees who are office employees. And I think most of us here might be culprits of this. And then inadequate physical activity, good that it reduced from 5% in 2014 to 3.6% in 2023. And then looking at physiological and metabolic risk factors, high blood pressure increased from 24.6% to 25.4%. Not significant, but we don't need that trend to continue. And then when we look at high blood glucose, we increased from 1.5% in 2014 to 3.3% in 2023. It looks small, but it is a significant increase in blood glucose. And then overweight and obesity increased from 19.3% in 2014 to 24.1%, a significant increase. So we are putting on more weight as we go on. And then disaggregating this by urban and rural, you can see that for current tobacco use, although it decreased in rural areas from 10.4% to 5, okay, that figure is not visible. But in the urban areas, actually there was an increase. Although on average we see a decrease, but in urban areas there was an increase. And then when you look at yes, by region, we had a decrease in all regions except in the northern region of the country, where tobacco use increased up to 16.3%. So we still have a problem in the northern part of the country. And then use of all forms of tobacco decreased in rural areas, but increased in urban areas. So we still have a big problem in urban areas. And then by region, decreased in all regions except in eastern region of the country. And then alcohol use, urban and rural, there was significant increase of alcohol use. And then also in by region, if you look at region, all regions increased alcohol use except in the central region, which is a bit, it was surprising to us that it is in the central region where we had a decrease. But in all regions, there was increase in alcohol use. And then inadequate consumption of fruits and vegetables, urban decreased, and also rural, there was a decrease. By region, there was a decrease in all regions except in the eastern region of the country, where there was an increase in inadequate consumption of fruits and vegetables. Physical inactivity, a decrease in all regions and also by urban and by urban and rural, and all regions except in the western region of the country, where there was an increase in physical inactivity. So we know where to focus our interventions. And then sedentariness, this was decreased in urban areas, but increased in rural areas. Probably this touches a little bit on what Professor Kamya was talking about. And the increase in all regions of the country. And then high blood pressure, increase in urban area, but a decrease in rural areas. And then by region, increase in all regions except western region of the country. And then high blood sugar, increase in all regions of the country and also in urban and rural areas. So this is a big problem. I think we need to pay special attention to this. And we know the consequences of high raised blood sugar. And then overweight and obesity, increase in urban areas, but increase in both urban and rural areas, and also increase in all regions of the country. And a big thank you to all individuals and institutions listed on this acknowledgement. And actually, we have gone ahead to analyze this data more deeply by other regions or by different factors, and there are quite a number of presentations that are going to be made during this conference by various individuals. Thank you very much.
Thank you very much, Professor Gua, today for the, telling us where we are with these risk factors for non-communicable diseases. I think you can see we are not doing very well. And I wonder, we are mentioned as one of the countries with the highest consumption of alcohol. I'm sure you know that. I really don't, this is a big public health problem. It's a big public health problem. And I don't know, certainly, as you know, at least we have an example. The president doesn't drink. At least that is a good example to emulate. But the Ugandans drink quite a bit. You go in the morning, you're going to work at 6:30 in the morning, and people are still in the bar drinking. So can there be some regulation about drinking? I mean, public health is not only medical, but it can also be laws but otherwise it's a huge problem. So thank you so much. These slides are going to be shared for those who have registered, and I hope you will find them very useful to refer to. Now, allow me to introduce the third speaker before our time runs out. Dr. Oyo Charles Akia is the Commissioner of Health Services, Non-Communicable Disease at the Ministry of Health. Dr. Oyo has over 20 years of experience in public health interventions, including clinical work at primary care levels and management of decentralized health services. He has served in local governments as district health officer. He holds a degree of Bachelor of Medicine and Bachelor of Surgery and a degree in public health from Makerere University. So Dr. Yo, you're welcome. After him, I hope we shall have some time for questions and discussion. Welcome, Dr. Yo.
Yeah, thank you, Professor, and the panelists. Good morning, ladies and gentlemen. Please just stand up a bit, rise up, stretch a bit, feel free to stretch, just stretch a bit. Hey, who is not getting up, please? Then say hi to your neighbor. All right, thank you. You can sit down. Thank you very much. Can we load the presentation? I'm really excited to be in this meeting today when we are talking about NCDs and communicable diseases at the same time. I think for long, we have not been doing much in that direction, but we have now started, and there's no turning back. We are going to maintain the momentum until we prevail. So if you are hearing about NCDs for the first time, please put up your hand. If you know your NCD status, please put up your hand. Hey, the rest they don't know. Okay. Now, okay, please, I will take you through the common shifts in how we are trying to address the rising challenge of NCDs in Uganda. The time allocated is not enough, but I'll try to work within the 15 or so minutes. Next slide. I thought I should just, I'm the one controlling. How do I? Okay, I thought we should understand what we are talking about. NCDs are basically disease conditions that are not transmitted from person to person. They are not infectious. Sometimes we refer to them as lifestyle diseases because they are very closely linked to the way we live, the way you eat, the way you drink, and the way you do very many other things. And the prevalence is most common among adults, but in our Ugandan situation, does not spare anybody. Whether you're a child, you live in urban area, you are in rural area, you are rich, you are poor, it affects everybody. And it tend to share some common characteristics. The causes tend to be complex. Others are not understood up to now, like cancers, for example. There are many multiple risk factors and takes long to manifest. You may get exposed like today or during early childhood, but the manifestation comes late in life. So you might mistake it for something else. And Yes, it leads to functional impairment and disability in most cases. So those are some of the common NCDs that we are talking about. Cardiovascular diseases, these are basically diseases of the heart and the blood vessels. In that category alone, we have over 15 different disease conditions. We have diabetes, chronic respiratory diseases, cancers of all types in children, in adults, accident and injuries, mental disorders, sickle cell disease, kidney disease. Actually, name any body organ that you know, there'll always be NCDs associated with that particular body organ. In Uganda, we have over 41 conditions that we have prioritized to focus on. WHO mainly talks about 5 or so major NCDs. But for us, we have seen we have over 41 prevalent NCDs in the country. Now, the risk factors, I think my work has been simplified. There are those modifiable risk factors, but we should not forget about air pollution, especially household indoor air pollution, and also environmental pollution. Now, I just thought of bringing out one common risk factor, that is physical inactivity and its contribution to the burden of NCDs globally. It has been noted that about 6 to 10% of major NCDs worldwide is attributable to physical inactivity, which is a growing trend in this country, especially for people like you and me, who is seated here in this room, the working class, the business community. You know, these are people who are mostly physically inactive. So physical inactivity contributes to about 60% of heart disease, 70% of type 2 diabetes, 10% of breast cancer, 10% of colon cancer, and also contributes to 9% of premature mortality. That is dying before the age of 70 years. Ideally, one should die when to, maybe, if you die like by attaining the age of 70, somehow, that is not premature mortality. The global burden, I think I wouldn't talk much about it, but we have to know that the burden of NCDs in terms of mortality is heavy in low and middle income countries, of which Uganda is one of them. And specifically in Uganda, about 35% of total deaths is due to NCDs. And a Ugandan citizen has a probability of about 20% of dying prematurely from one of the 5 main NCDs. 1 in 5 of you seated here, God forbid, will succumb to NCDs. I think the risk factors has been mentioned. I think I'm not going to talk much about it, but we have seen that the burden of NCDs over the last decade has more than doubled in some of the conditions, and we need to do something about it. That is still about the burden. I would not dwell much because it has already been mentioned. So what are some of the drivers? We really see that as the countries developed and with the increasing level of urbanization, we tend to get into, development of more NCDs because of the prevalence of the risk factors. The dietary pattern generally has shifted. The kind of foods we eat today is not the kind of foods that our parents used to eat. So that is a very, very big problem. I know the food is very tempting, very tasty, very nice, and then that is where you run the risk of, if you are not disciplined, of eating all sorts of junk food. You may enjoy, say, okay, let me eat once, maybe after all, it is only today, but that thing is cumulative over time. It is cumulative over time. Self-discipline in eating is very, very important. It's very key, especially the fast foods, especially the foods that we eat away from home. At least at home, you can control or regulate what you eat. But foods eaten away from home is very, very dangerous. With the improvement in the means of transport and communication, generally, we tend to, run the risk of developing NCDs. I think that should be self-explanatory. We are seeing many cases of injuries. That is one of the NCDs. We are seeing use of, people are exposed to harmful materials, using the media and all that. That is also very bad because you tend to develop some of the NCDs, including mental health disorders that we talked about. What are some of the priorities that we have? Number one, when you look at the risk factors that have been presented, these risk factors are outside our mandates as a Ministry of Health. But we have other MDAs, many other government actors and non-government actors that are very, very crucial in the prevention and control of NCDs, including the civil society organization, private sector, actually everybody. If you're in this room, you have a stake in the prevention and control of NCDs. Number two is addressing modifiable risk factors. These factors, risk factors that we talked about, the modifiable one, we can't do something about it, either at individual level or at community levels. But we know that prevention at the community levels requires policy and regulations. Then enacting and enforcing laws, again, is some of the culprits like tobacco, excessive alcohol consumption or marketing of alcohol, and marketing of unhealthy foods. These are foods that are high in salt, high in sugars, low in fruits, low in veggies, and also high in bad fats, saturated fats, fats that are solid at room temperature. I don't want to mention them, but just imagine, think about it. Any fats that is solid at room temperature is not really healthy for human consumption. If you are to consume, you have to regulate the quantity or the amount. Then promoting active lifestyles, mainly in urban areas, by developing walkways and cycling lanes, and having roads that would allow people, pedestrians to walk, and those who would like to cycle to also ride. But our roads in most of our cities is quite disturbing. But I'm happy. I think some of the new cities that are coming up, they're trying to address this. And providing regular screening for early detection and treatment. Ladies and gentlemen, this is the way to go. You have to know your NCD status. The good thing is, when you work on it, you can reverse the progression of the disease, either from the physiological or metabolic risk factors. You can revert back to the normal status. If you have NCDs and you again address it, you can reverse and go back to almost normal status. But that requires a lot of discipline. And here we are promoting wellness clinics. This one came up in the previous sessions. It is very important in other countries. It is the way to go. It's a routine. But here is something that we are trying to adopt and also popularize. Okay, some of the key shifts. We are moving away from focusing strictly on preventive, from curative to preventive idea. And here we are we are emphasizing lifestyle modification at individual levels and limiting or avoiding exposure to the risk factors. That is primordial prevention. That would be Very, very important. And also the second focus, safety is, we are moving away from vertical to integrated health service delivery. That is the focus of our stay here. This has been well elaborated by the previous speakers, and that should be the way to go. Before the wave of integration came in full swing, our focus was to integrate NCDs into HIV/AIDS. We had started that and we had moved very well. But now we realize that we can broaden and go beyond that. And also raising awareness with a focus of changing behavior through sustained public education, health promotion and public education. This is very, very important. I know there are people who are specialized in that areas, very good communicators. Please, if you know you are one, do your part and do it very well. Because whether we are talking about communicable diseases, whether we are talking about NCDs, the main thing relies on awareness creation. That is the starting point. If we are strong in that area, then we are going to be dealing with a population that is already informed and they know what to do and they support us to prevent or control. I think that is where we have to put our investment for the partners that are here. We are moving away from working as the health sector alone to having the whole of government, the whole of society response. I talked about the risk factors. Others are best handled by the Ministry of Agriculture, the foods related thing, right from production, storage, and the distribution, maybe marketing now, Ministry of Trade comes in, and many other actors. So it is a collective responsibility. The whole of government approach, the whole of society response. Everybody, all of us, nobody should be left behind. Now, the funding that we have currently is like linked to diseases, but I think we need to move away from that siloed kind of funding mechanism to holistic and sustainable domestic financing for NCD program and also for communicable disease programs in the country. And we have to adopt digital technology and technology generally, and use of artificial intelligence to improve patient care. This is very important, especially having point-of-care devices, having the mobile or the portable, mobile laboratories, and use of artificial intelligence to limit or to avoid subjectivity in diagnosis and patient care. This is the way to go. It's very important, and I think we're already doing some good work in some of our institutions. An adoption of self-care as one of the strategies to improve the quality of lives for people living with chronic diseases or NCDs. Gone are the days when we imagine that we as clinicians or service providers, we know it all. No. Patients themselves are experts in some of the conditions that they have. They're our experts. You remember one of the members said that they are like, professors, when you ask them about certain things, they first have to Google and they know. But for them, they know. They are people with lived experience. So they should be part of the discussions. They should be part of the decision making. They should be part of the service delivery and any policy change that we have. Well, as we do that, we should be mindful that the opportunities. The low prioritization of NCDs in national planning is something that we should dwell on, we should focus on. The limited awareness among the public and the policymakers is also a hurdle. This is something that we are trying to address through NCD multisectoral committee. And then the aspect of insufficient screening and treatment facilities, the weak enforcement of the existing laws and regulations, things that we can do together. So ladies and gentlemen, we have to work on research and surveillance. We need local evidence to provide, local solutions to the problems that we have in this country. Because most of the statistics that we have, or what we quote, some of them are generated from elsewhere. So if we do it locally, that would be much, much better for us as a country. I'm almost concluding, being reminded that my time is up. But this thing is very slow. Okay. I just want to conclude with this picture. It's saying sometimes it's necessary for us to give, to give yourself advice. Self-advice is valuable because you know yourself better than anyone else. Take time to reflect on your life, identify obstacles, and make changes that are impactful for the good of yourself, for the good of the family, for the good of the community, and for the good of the country that you live in. Thank you very much for God and my country.
Thank you very much, Dr. Yo, and thank you very much, our three speakers. I'm sure you have learned a lot from them. I'm really tempted to say protocol, but I said I will avoid that because to mention is to omit, and I don't want to mention anybody lest I miss somebody. So all protocol observed. Now we are going to have a short, a short time of questions. We're going to take just one round of questions, and then the panelists will answer. If you put up your hand first, you will get a chance. But mine are very small. These statistics that I mentioned about the rural folks, the rural people, are they also more sedentary? I don't know who will want to answer that. The non-communicable disease, what do you think is happening in the rural areas? And then, Dr. Stavia, we talked about if we are to prevent deaths and severe malaria, people must seek treatment early. They should not go to one drug shop and another drug shop before they go to where they should get proper treatment. How are we going to deal with that? I know you may not have the answer, but in case you have some insight. So any questions from the floor? Yes, you make it very, very precise, and only one question per person. Yes, oh, you don't have a speaker. Can you shout? You don't have a microphone.
Thank you very much. This is Semambo from Fastback, IDI. I would like to direct my question to a concern. We wanted to prevent non-communicable diseases by also regulating the consumption of alcohol. I remember we said we are going to work with other partners like the trade. So how are we going to put up policies that are going to regulate alcohol consumption without affecting the economy? Thank you very much.
Thank you very much. The commissioners will answer that. They have. Dr. Mansour.
Thank you so much, Professor. Just a question regarding the risk factors of NCDs. I didn't find any figure regarding the salt intake in Uganda. And
regarding what?
Salt intake.
Okay, salt intake.
Yeah, that is very important. And also regarding the excess energy intake. Those are very important in relation to the high blood pressure.
Could you repeat the second one?
Excess energy intake. Excess energy intake. Because excess energy intake is very important regarding the obesity. And also the salt intake is very important in relation to the all chronic communicable disease, particularly CVDs and high blood pressure. Thank you.
Yeah, thank you. Any other quick one? Yes?
Thank you so much. For all the presenters, we are looking at integration and prevention. And as far as I understand, Uganda has the least, Ministry of Health is one of the least financially looked at aspects of Uganda's economy. And then when we look at health financing, still prevention is the least. We focus on treatment and all that, and still we are lacking. Now, with the donors' money going, I've not had our Ministry of Health and also our Ministry of Finance talking about increasing the health budget. I don't know if you have the Ministry of Finance presented here, because I think they really need to hear about these things. Where are we going without having the money to do all that we are talking about? Thank you.
Yeah, thank you very much. I think people will comment about health financing.
Thank you, Prof.
Yeah, please. I'm about to bring it. Yes.
This is not a question. I want to supplement your submission about sedentary lifestyle in rural areas.
Oh, you are answering.
Yes, my name is Chigongo Andrew. I work with St. Patrick's
Except
Hospital.
that I didn't ask for the answers from the floor, but can you make it like in 3 seconds?
Okay. The issue about sedentary lifestyle has come to light. I was discussing with my grandmother when I told her stop working, I will give you some money every weekend. And she was like, when I go to the garden, I am actually making physical activity. When you tell me to sit down, then I might get any disease. So I thought we need to learn from these people and not just impact what we think to them. Now, with the working class, we are telling our parents back home, sit down, I will do everything you want. And then at the end of that day, we manage their non-communicable diseases.
Yeah. Thank you very much. Please don't tell your parents to just sit down and you say, I have enough money, you know, you don't have to dig, I'll buy the food. Thanks for that contribution. I think we...
Prof, just one. Yes, Professor.
Yes.
This is Nathan from Baylor. Dr. Stavia, what are the possibilities for enforcement? Because the data is available. Too much liberalization also is a cause or a driver of these NCDs. Where can't we enforce alcohol consumption, regulate the timing, things like that, so that we control these NCDs? Thank you.
Thank you.
Yeah, thank you. Professor, the last one, maybe.
And we stop.
Yes, the last one. Thank you, Professor, and I want to thank the Commissioner for opening up our eyes. One thing which is very clear now in Uganda and across the globe is that health has become a private good which has left the law of market to determine whose health is profitable for investment and whose health is not profitable for investment. Why am I saying like that? When you go to many supermarkets across the country, you're going to find ultra-processed foods. And UNBS is there, or National Drugs Authority is there, and all other agencies that are responsible for regulation. Too much salt, too much sugar. And many people are walking up there and they are taking Pringles and all that. And of course, at the end of it all, we shall end up in Mulago, in other highly specialized units across the country.
Yeah.
Now, what does it take? Yes, an empowerment that the Commissioner has talked about is key, that we must spread the message that you must take it upon yourself to begin to train yourself to get off the risky habits, but also to implore the children and all other family members to exert influence on their health determinants. But also we should not stop there. But at the policy level, we need to do something to regulate what comes into the country as far as the health risky foods are concerned and beverages. Thank you so much.
So it's kind of regulation. Yeah, I get the point.
Yes.
The last one, just, the person in
yes,
white.
thank you very much.
Oh my God.
Yes, my name is Sechanzi Charles, a nutritionist, and I work with MRC UVRI. Yes, my question really goes to the panelists who are presenting on NCDs. Yes, some data was displayed on fruits and vegetables. Then I really got concerned. And it was someone mentioned there that Uganda is a part of Africa, but you have a lot of you have a lot of greens in our country. So my question goes back to really what is being put up as enforcing, ensuring that something is being done, especially from the community aspect. So this question goes to the people from the members from the Ministry of Health. What are we doing to ensure that at least some health workers, especially the nutritionists, are being put on board to ensure that this information is delivered from the community basis or about nutrition? Huh? Also, I'm going to ask a question to all of us here. I know many organizations are here. How many of you are running projects and are concerned with NCDs, especially community-based projects, and you have a nutritionist on board who is ensuring that this information on diet is delivered very well? Yes, I thank God that I'm running a project that is on NCDs, and we are educating people on community basis on what healthy diet means. So all those questions, I'm leaving them to you as my seniors to think about them, to see how really can we change this trend of fruits and vegetables. It is something that can be changed. People can adapt to this, but who is delivering this information to the communities? Yes, thank you very much.
I'm really sorry this session is very interesting. You can see a lot of interest. Now, I would ask the panelists, just, you don't have to answer in detail, but you just come and make a few comments on whatever you have picked. So should we be in reverse order? Reverse order. Dr. Yo, just 2 minutes. 2 minutes, and then we have Professor Gua today, and then we have Dr. Stavia. What is the reverse order?
Yeah, thank you very much for the questions and comments. Yeah, I think I'll leave the sedentary behavior to Professor David. Is that okay, Professor? Okay, about alcohol consumption, the policy aspect. Ladies and gentlemen, when you are regulating, you are not stopping consumption of alcohol, but you are restricting. We are aware of the economic implication and where we are as a country, but we have to regulate, especially the time for consuming alcohol. Those who spend times in bars, these are people who are unproductive. They are unproductive, so they should be engaged in productive activities in order to generate revenue to support the country. So it is about restriction, not stopping. And if you are consuming, consume responsibly. But I would like to say that no any amount of alcohol is safe for human consumption. If you can avoid it completely, that will be better for you. What is there for you to drink? About the salt intake, I think that statistics was presented. In Uganda, we consume about, according to that survey, I think maybe I leave that one to you, Professor, because that is what you did, but I also have the answer anyway. Now, increase in health financing, I will leave it to Dr. Stavia, but that is also something that I raise it as a concern. Now, nutrition is being brought on board. Colleagues, maybe in my opening statement, I talked about collective responsibilities. Do your part. We also do our part as government. As Ministry of Health, we also do our part. But let me tell you that we work closely with different civil society organizations that have nutritionists, and also individuals that have nutritionists, I mean, with that skills. So we are together. Is Kamara around here? Kamara, are you in? That is Kamara is not, I think today, maybe he hasn't come. Is one of the senior nutritionists who has always been working very, very closely with us. So we are together in this. We are not leaving anybody behind. Please, it is our disease, and we have to address it together, collectively, leaving nobody behind. It requires different skill set. Bring in your expertise, bring in your skills, bring in your ideas, and let's work together for the good of this country. Thank you.
Yes, thank you very much. I think the first question was on sedentary behavior in rural areas. Yes, we have, and I presented those figures. It was on one of my slides. Sedentariness increased from 24.7% in 2014 to 30.7% in 2023. That is in rural areas. So you can see even in rural areas where you would not expect, at least personally, I would not expect that sedentariness would be increasing in rural areas. It is. These are the figures, national figures that we have. So those are the figures, whoever asked the question. Maybe to add, a related question that I've often been asked, can you have high levels of physical activity and also have high levels of sedentariness? Yes. And the figures also show that actually it is possible. We have very high levels of physical activity, over 95%. But also we are having increasing levels of sedentariness. How does this happen? You can even demonstrate it very easily among office people who have jobs in offices where we sit the whole day. And then in the evening, you can go to the gym, do the 75 minutes of physical activity in the gym, but you've been sitting the whole day. So although the physical activity you do at the end of the day can offset part of the risk, it may not eliminate entirely the risk imposed by the sedentariness that you have had the whole day. So we need to pay attention to these. These are two different risk factors independent of each other. Research has demonstrated that. Now the second question was to do on salt. In the last survey, we tried to do that, and we collected urine from participants so that we could measure dietary sodium in urine. I'm sorry I did not include those figures, and I don't have them here with me, but we have those figures. And one of the suspicions we have, I hope this mic is working. Okay, yeah, what the figures the suspicion we have, and we are yet to analyze it more deeply, is that most of the raised blood pressure that we are seeing is being driven by high consumption of salt in the food that we take. And I think this is one of the advice that Dr. Oyo has given, that we should be careful when we eat outside of our home. We can control what we eat in our homes, but sometimes when we go out, the food is already prepared, the salt is already in. But our suspicion, and we are going to continue to analyze this, is that we are consuming a lot of salt, and it is partly the reason why we are having high prevalence of blood pressure. The same with the starch. This is to do with the diet. And we have collected information on that, and there's more detailed information on that. I think those were the questions that were directed to me. Thank you very much.
Thank you, Chair. Thank you, everybody, for the questions. How can we make people come early for diagnosis? I will not only talk about malaria, it cuts across communicable and non-communicable diseases. I think we need to come out with a strong resolution from this conference on how we can engage the communities to know about these conditions and be able to come out early. But we can also improve on the accessibility of our services, integration, we have talked about it. When I come for my hypertension medication, you can help me to assess if I have other conditions. We also need to make the services available at the doorstep of our people. We have a number of examples that have helped us to improve access. You know about the CAST Plus, you know about the ICCM. These have helped in reducing and improving the diagnosis of conditions early. On financing, I will not dwell a lot on it. We as a sector are engaging with finance and our development partners to see how best the resource that we get in health can keep improving. The government has been improving the financing for health over time and is still advocating for more resources, and we hope that health will become a development matter in our country one day. We need advocates for that. Without healthy people, the Vision 2040 cannot be a reality. Thank you.
Yeah. Thank you. We've come to the end. Thank you for mentioning accessibility of health services. I know the ministry is promoting Choose, and we have also village. I think you need to get down to the community so that services are more accessible. All services for communicable and non-communicable disease. So thank you very much for attending this session. I'm sure you've learned something, certainly based on the kind of interest and questions. I'm sure people have really enjoyed this session. We are sorry for going over by several minutes. Would you like to like make some administrative comments? Or you want me to? I finish. No, I'm done. I'm done. So thank you so much. Can we clap for our panelists? And clap for me as well.
Okay, thank you, Prof. Kamya. Actually, I wanted you to go off stage so that we can clap for you. Appreciate Professor and the team for leading us through the first session. You can take your seats. So, ladies and gentlemen, we've come to the end of the first session for today. Our next session will be the official opening ceremony, and we kindly request that we keep time. We are going to have a short break for tea, and our tea will be served outside. For the heads of institutions, the Minister of Health senior leadership, and the executive directors from different organizations, our tea will be served right at the registration point, and the ushers will guide you. The rest of us, tea is downstairs. People with posters, please ensure that you see the organizing team, and the organizing team should stay behind as we prepare for the official opening at 11:15. Once again, appreciate Professor and the team for keeping time and guiding us well through the first session. You're welcome for tea, and let's keep time. We appreciate the sign language team who are with us here today, and people are following them online. Thank you for being part of this.
So people who trained a long time ago may not be very aware of the distribution of childhood illnesses of dates, but also more information is out there. Research is being done, and there's more new knowledge. So the in-service training alone is not enough. The pre-service training. We need to do more.
We bless your name. We acknowledge that this is the day you have made for the annual conference for the communicable and non-communicable diseases.
We are going direct into business in this pre-conference, and we have a number of organizations that will be leading us in the pre-conference.
You've already been welcomed to today's conference, and we are privileged as the Uganda Pediatrics Association to set the stage and kick off the conference.
We encourage our patients who have asthma to have daily inhaled corticosteroids as the mainstay of treatment, other than using salbutamol whenever they need, because continuous use of salbutamol is associated with hyper responsiveness, or your chest responds worse, what people call addictive to the drug.
In order for us to address, everyone needs to know what sickle cell disease is, how it is transmitted, who is at risk of getting it, not when they have grown and they're going for premarital counseling. It's too late.
Many children are actually not looked after by their own parents. They're looked after by guardians. And I know there's still a little bit of stigma in almost all diseases. How are we handling that?
Richard, we appreciate that actually the half-life of dihydroxypyperaquine phosphate, DP you mentioned, is about 42 days. But I note you are giving it weekly in sickle cell disease. What would be the sequela of prolonged use of DP, given that actually it's given weekly compared to its half-life of 42 days?
Do you think children with asthma it's okay to engage in all these kind of activities?
Ministry of Health, we really need to up our game and ensure that we have these screening kits for sickle cell at the NMS and they reach to all government facilities. Thank you.
Out of this conference, what are we saying we can do next year, beginning January, to make sure that our communities are saved from some of these probably easy to solve problems? Thank you.
I used to think that asthma and sickle cell diseases are not treatable. I'm just getting to learn from the presentations here that we can treat these diseases.
Sickle cell disease in the country, about 20 to 30,000 babies born every year with the disease, and Uganda has number 5 with the biggest number of sickle cell disease worldwide. So we need to work together, Ministry of Health and other partners, to address sickle cell disease and other non-communicable diseases. And I suggest that capacity building is built not only for health professionals, but for everyone, so that we can sensitize the community and also provide good services for the patients.
Conference is actually an excellent platform because it brings together different stakeholders, not just from the clinical field, but also from civil society and other supportive fields in medicine. And why is this very important for pediatrics is because taking care of a child, like traditionally we say it takes a village to raise a child, but it takes the same village to actually take care of childhood medical conditions. And I'm excited that the Uganda Pediatrics Association was invited to this conference, and we kick-started it because children clearly are our future, and we got a chance to shed light on the burden of NCDs in children and some of the commonly mismanaged or not very well-managed conditions in children. So this has been a great platform for us, and we hope that every year we'll continue to share and raise more awareness. Traditionally, childhood illnesses have been reduced to just acute illnesses, cough, flu, pneumonia, malaria, but that is even just a tip of the iceberg. Childhood illnesses are broader than that. And today, really sharing on NCDs in children, whatever we touched on was just a little bit, but children suffer from any other chronic conditions that adults may suffer from. Things like diabetes, developmental abnormalities, other endocrine abnormalities that affect children. And we hope that with time we'll continue to spread more awareness. But this was actually a very great platform for us to begin to raise this awareness and build capacity.
This will be the new home of the School of Public Health at Makerere University, the first institute of its kind in sub-Saharan Africa. For more than 70 years, the school has stood at the front lines of Africa's health, training generations of leaders who have fought HIV, Ebola, Marburg, and COVID-19. Their work has saved millions and shaped the future of public health across the continent. But today, our impact has outgrown our walls. We rent scattered spaces, stretching every resource to teach, to research, and to respond to the next crisis. That's why we are building a new purpose-designed home, a place for innovation, collaboration, and training of the next generation of public health leaders, because Africa's future depends on it. Right now, the continent has only 80 public health researchers per 1 million people, compared to a global average of 1,081. This shortfall threatens our collective health security. Every lecture room we build, every lab we equip, and every mind we train helps close this gap. The $10 million project is already halfway there, powered by, of course, the generosity of our staff, students, our partners like the Rockefeller Foundation, the US state government, NUFIC, plus, of course, many others. We invite you to join us in investing in the future where knowledge saves lives and where Africa stands strong on its own expertise. Because the future of Africa is its people, and their future depends on public health. Makerere University School of Public Health, building the future of health in Africa.
We are grateful for this conference, the 19th JASH conference and the first national conference on communicable and non-communicable diseases. It's a very good opportunity for us to publish and share our findings from the field in Mbale. We have some of the evidence which shows an improvement in the PLE results. So we are very excited about mental health. Mental health is very critical. You can see the impact on health, impact on people's lives, impact on the teachers' lives, and everybody around us. And really one of the main things that came out today was that we need to have all sectors involved in this particular issue. It is a multidisciplinary issue and we need everybody to be on board. So thank you so much for this opportunity.
Non-communicable diseases now account for more than 1/3 of deaths in Uganda. Hypertension alone affects nearly 1 in 4 adults, and diabetes is rising quickly, especially in our urban areas where unhealthy diets, sedentary lifestyles, and obesity are becoming